I would like to invite Professor Gautam Ganguly sir to chair the session, the oration session, and Professor Ashish Dugal sir to chair the session and introduce Professor Debashish Chowdhury sir.
Good afternoon. It's a privilege and honor to introduce Dr. Debashish Chowdhury, although I think it's a thing which everyone knows Dr. Debashish Chowdhury. He is currently the face of headache medicine in India. He's the immediate past president of Indian Academy of Neurology, and he has been the head of Department of Neurology at the Institute of Postgraduate Medical Education and Research. And during the past several years, I have had the good opportunity to work under him, to learn from him. And I believe everyone here knows that Dr. Debashish Chowdhury is the master of headache medicine. What he teaches, what he tells, these are pearls of wisdom for treating patients with headache medicine. And I will not take further time, and I would invite Dr. Debashish sir to give this oration on management of migraine, how it has progressed from Ergots to the monoclonal antibodies.
নমস্কার সবাইকে আমার অভিনন্দন জানাই। দিল্লি থেকে আসা এবার একটু মুশকিলে ছিল, কারণ আমার একটু ফ্যামিলি ক্রাইসিস চলছে, কিন্তু তাও সমস্ত বন্ধুদের এবং শুভাকাঙ্ক্ষীদের অনুরোধ এড়ানো অসম্ভব, তাই আপনাদের কাছে এসেছি। অনেক অনেক ধন্যবাদ। Thank you very much for giving me this opportunity and your warmth and love and affection, and I value it. I'm a hardcore Bengali, and obviously I don't stay in the city, but I belong to the city, and I think that I have most of you are like real brothers and sisters to me. So I have been given this topic by them, and again I congratulate the organizers. And it was mentioned in the morning that the names were given, very catchy names, people and mentioned it, the topics and all. So this was also given to me. I didn't decide about this. So this topic heading, but I think it's apt that 4 decades of headache neurology from Ergot to Erenumab, what we have really learned, and I can assure you. In the next 30 minutes or so, I'll show you some of the things which really we have learned and which are actually making a great change in the way we see headache medicine and the way we practice headache medicine. So this was the story of Ergot. It was discovered by Edward Rockies in 1882. He was the ENT surgeon, and it was a serendipitous discovery, because by that time it was known that the ergots was used in obstetrics because of his vasoconstrictive properties, right? And he actually envisaged, because of the background knowledge, that probably there is this flushing of face, vasodilatation in migraine, so probably this might be helpful, and it was used. And actually the ergotamine was synthesized by a Swiss biochemist in the year 1912. So this was again a story that has been repeated again and again in migraine and the headache field, that we had serendipitous discoveries like propranolol. A physician in US saw that when he was giving this drug to his cardiac patients, their migraines improved. So it came into being and started to be used as a prophylactic treatment. Similarly, Botox, when this was injected to high-end socialites for their facial purposes, it was found that many of them had actually relief in their migraine, and that also was studied subsequently. So the serendipity was a great part in played a great role in headache medicine. But actual scientific literature started coming in 80s. So last 4 decades. So these are the two key lectures. I don't know whether this is not showing it properly here, but anyway, this is the first paper was by a person of in US called Michael Moskowitz. He actually did and studied the pain. He was studying the pain pathways and the inflammatory response that is generated by the pain pathways in animal model at Harvard, right? And the other one was Jess Olison in the Scandinavia. So he was trying to see that what is the change in the vascular tone and vascular supply that is happening during the migraine attack. He started using xenon and then later on moved on to the other advances. So both of them actually pioneered the way we see migraine, because there was this migraine is an old disease, like 5,000 years, right? There was always this idea that, and it was basically propagated by Harold Wolff, who said that it's basically because of the vasodilatation, that is the headache is occurring and vasoconstriction leading on to aura, and that's migraine. But it became much more than that, and the central circuitry, the brain as an originator of migraine attack started coming, and this is Moskowitz model which he drew at that time, and this is the model that we are following now, is that we have got some trigger which is affecting hypothalamus, as well as there are peripheral triggers, peripheral cutaneous this thing, and then they are affecting the dura, the blood vessels in the dura mater, and from there going to the trigeminal ganglion, then there is the trigeminal vascular pathway, and that is basically going through the brainstem, and there's a lot of pain circuitry in the brainstem, locus coeruleus, and then again is going back to the hypothalamus and the cortex. So the interaction between this ascending and descending pathways become very important. This particular loop between the trigeminal ganglion and the cervical areas become very important. And there is a feed-forward loop of pterygopalatine ganglion in animals. That actually helps in maintaining the parasympathetic effects of the headache, and particularly conspicuous in cluster, but also in migraine. And then there are components from C1 and C2 which are actually affecting the, contributing to the cervical complex here, and that also have a lot of modulatory effect on head pain. So this model, once it got entrenched and people started working on it, the things started changing. And then when these models were applied, and in 80s, mid 80s, Peter Goatsby was a young man. He visited Lars Edvinsson in Scandinavia, and then what happened? Then they started having a collaboration, and then they identified the CGRP. Now CGRP, calcitonrin-related peptide, gene-related peptide, is a polypeptide which is basically from the calcitonin family, but it has got a completely different action. It is involved in the pain mechanism. It is produced by the reverse splicing of the mRNA, and this became a canonical peptide, and the identification of a receptor, how this polypeptide is acting on the receptors, especially in the trigeminal ganglion, in the brainstem, in the cortex. So that became the hallmark of the further studies. So those two studies and these two studies, these four people got the brain prize because of the highest prize in 2021 because of the Moskowitz, Lars Edvinsson, Peter Goatsby, and Jess Olison. So the headache story began. And by 2025, as we stand today, the headache medicine has arrived. There is no doubt about that. I'll show you how and why I'm saying this. That you no longer can ignore headache medicine, right? Because one, that there is a widespread acceptance of the ICSD classification. Now this classification came up very late in 1988, right? But over these 4 decades, it has now entrenched, and all of us communicate through this classification. When I say migraine, I mean a certain migraine defined by ICSD criteria, right? And you also know that. Most of the general physicians are also now knowing about this classification. If not the nuances, the basic tenets of this classification. So that is very, very important. Second, we now have world over the better estimates of the magnitude of the problem, and also we have better estimates in India. That has become a very, very important step in diagnosing and managing headache medicine. Then of course we started having migraine specific drugs. Gone are the days of serendipity. Now we have focused pathways and focused polypeptides, neuropeptides to target, and therefore we are getting more and more migraine specific drugs. This is a tremendous development in the last 4 decades or so. We are also actually, because we are knowing the kind of pathways, so therefore we can set up the targets for neuromodulation, and this is becoming an emerging field, and we have got already a lot of devices, and I think more are coming, especially with the use of AI. Now the non-invasive neuromodulation sphere is going to see a tremendous good growth in the coming next 10 to 20 years. Then we have got botulinum toxin, as I said, that was serendipitous discovery, but then was proven by a randomized controlled trial. And now we have got a lot of injections, the peripheral nerve blocks, especially the greater occipital nerve block. So I have done a lot of work because that's cheap, that is easily available, that can be given very easily. And it is very suitable for third world countries like us. And we need to take on this. And now a lot of my students are across India are practicing it. And Origin also knows how to do it. He has got one thesis on this. So I think that this is going to spread all over India and make a good change. And finally, as I was talking in the morning, that we have realized that migraine treatment is not just by drugs. It has to take into account the biopsychosocial approach. That means that we have to take out the environmental factors, the stress that is commonly associated with it. We have to take down to the other modalities like meditation, yoga, like lifestyle modifications, along with the drugs. And more importantly, and probably the most important is the teaching part, the therapeutic education. The education can become a part of the therapy, right? When you tell the patients about the disease, you educate them how to take the drugs. You spend that much of time, tiny bit of time, then that makes a huge difference in the outcomes that has been shown again and again by various studies. So today I'm not going to talk about all of this. I'll just be telling you about the stories about the migraine-specific drugs and how they have made an impact over the last 4 decades. So before that, the classification. Now, classification, as you know, that we have got 4 classification versions till now. About last classification we have that is in 2018, ICSD 3, and the new one is coming in 26 or early 27. No classification is perfect. What we have done with this classification, that we have stopped using ambiguous terms like commonly, generally, or something like usually, something which do not mean anything. As you were saying that there is a lot of objectivity, lack of objectivity. Yes, lack of objectivity is there. There is subjective, but then if you make your communication through that specific words that are given in the classification, you will arrive at a right diagnosis most of the time. So this has made a lot of difference. No classification is perfect, so there are scope for improvement, and this will keep on happening over the years. The other thing is this, that this classification gives you a scope to tell about this disease in general terms. If you are not interested in headache medicine but just still see the headache patients, okay, fine, that's all right. But you just mentioned this common diagnosis, migraine, tension type headache, attacks, or other primary headaches, right? So this is the first coding, but if you are interested, then you go more up, and then you use the 2-digit coding like migraine without aura, with aura, chronic migraine, various types of migraine. You have to read that and you have to know the classification, and then you can go to the 3rd or 4-digit coding in tertiary care headache clinic or center. About the magnitude, disability and burden. Now this is the paper we produced last time from a survey of the Delhi NCR region, and as you can see, and it matched closely to the paper that was produced in Karnataka state, from the Karnataka state in 2016. So that actually showed that it is more or less similar. And you can see the migraine as 26.3%. That is about 1 in 4 adult patients in the National Capital Territory area had 1-year prevalence rate of 26%. They were suffering from migraine. And if you see the proportion of probable MOH and other age 15 plus, that means the headaches 15 days or more, that is also a considerable amount. And that usually, the 15 days or more headache group is usually the chronic migraine group. So that is about 3 to 4.5%. So there is a huge number to deal with. And that actually has been shown by a GBD study paper, which was published in 2019, which shows that in India we are having about 214 million people suffering from migraine, right? 214 million. That's humongous, actually. And actually, in the same year, a little earlier, we had produced our result, and that we calculated that it is about 211 million migraine patients. But more importantly, about 25 million are having chronic daily headaches. 25 million people. So you like it or not like it, all the specialties taken together, generalists, physicians, ophthalmologists, rheumatologists, neurologists, neurosurgeons, you like it or not, these patients are going to come. Some of them will be easy to treat, some of them pediatricians, some of them will be easy to treat, you can treat them, but some will be very, very difficult, and they will start knocking door after door after door, and that is the story, and therefore we should pay attention to headache medicine. That is very, very important. What about the disability? Now, in neurological disorders, we call about DALI. DALIs include the deaths and disability, right? In headaches, nobody dies actually. Migraine, directly nobody dies of migraine. So therefore, we call it YLDs. But still, Gagandi's paper, they have shown that 16% of the DALIs of the non-communicable diseases is because of migraine only. That's a huge chunk. Again, so and if you see the overall this thing, YLDs in the world, then you'll find that persons below 50 years of age, the commonest disability is because of migraine. So that is the importance of the disease. Now, in another paper which we just published in 2025, we have now shown that this is also not simple. I mean, it's not that migraine, kind of just a mild attack. No, you see the intensity in a scale of 1 to 3, it's 2.1, right? They are having a large proportion of their time spent in ictal state, 8.2% in a month, and the lost health is about 3.6%, right? So therefore, the migraine actually demands closure attention, closure care, and more knowledge about how best we can treat these patients. And same thing escalates when you go to the probable MOH and headache 15 plus. So I will talk about the 4 decades and the 4 breakthroughs. The first is of course the triptan, the 5-HT1B1D agonist. All of you know about this. This was actually done because of this pioneer work. Many of you might not be knowing about this. This is Dr. Pramod Saxena. He's a KGMU graduate, and he went to Netherlands and worked there he's a pharmacologist by profession, and he worked on these 5-HT receptors, and he named as atypical 5-HT receptors, which later was named as 5-HT1B receptor, right? And because of this, and he was the person who actually gave the name triptan, and because of this pioneer work, and the basis of this work was basically simple observation that serotonin depletion occurs from blood platelets leading to loss of cranial vascular tone. And the Patrick Humphrey discovered sumatriptan, which was the first sumatriptan developed as a 5-HT1B1D agonist. And he was knighted OB, he got the OB award for this. Now we have got 7 triptans, as you all know, and in India 6 are easily available. Provatriptan is a little difficult to get. So I have used all types of it, and sumatriptan you have got a lot of routes of administration like subcutaneous, oral, intranasal, transdermal. Now, 25 or 30 years of use of triptans, what has taught us? More or less the same in terms of efficacy, if you could. Though there are individual finer points, differences in that. For example, sumatriptan has got a very poor bioavailability when given orally, but subcutaneously it works very well, right? Rizatriptan and the L-triptan at a dose of 10 mg and 40 mg respectively are more likely to produce the optimum results with the least kind of side effect. Zolmitriptan is quick to act. Provatriptan and naratriptan are slow-acting triptans, and therefore they can be given as a small transient prophylactic therapies like in menstrual migraine, like in sometimes when you have these patients who are having specified trigger, consistent triggers which are causing the headache, like exams, before exams and things like that. So the triptans has been in use for a long time. We now know about the triptan symptoms, that people have this chest constriction, breathing difficulty, palpitations, dizziness. So you have to warn them before prescribing them. And also they are contraindicated in patients with coronary artery disease, cerebrovascular disease, uncontrolled hypertension and peripheral vascular disease. Now, most of the migraine patients are in the younger bracket, so you expect there might not be that much of coronary artery disease or hypertension, but you have to take a blood pressure. I can tell you that a lot of young migraine patients are actually hypertensive. They also have dyslipidemia, right? There is now emerging vast literature that is coming up that they carry along with their migraine significant vascular risk association. So you have to be careful in that. So that's a problem with triptans. But what do triptan do when you analyze their effects? So there are 4-step problems, right? First is that you have to see that how much pain freedom they get at 2 hours, how much pain relief they get at 2 hours. Pain freedom is no pain. Pain relief means from severe to moderate to mild, right? Recurrence within 24 hours, and what is the most bothersome symptom. Now this is a concept that has come lately, that was not so much prevalent when the initial triptans were being investigated, that people might be more troubled not just because of the headache, but more troubled because of the associated symptoms like nausea, persistent nausea. Persistent, I have patients who have persistent photophobia or persistent phonophobia. So what is these acute drugs are doing to these most bothersome symptoms? It is important to know these 4 essential outcome parameters because we will be comparing them with the newer treatments. Now, problems with triptans are that they have variable efficacy, right? And and that is the intra-individual variations are there. There are about 30 to 40% patients who are poor or non-responders. A majority of the triptans which are of shorter duration and quick action, they have a headache recurrence rates, right? And that may go up to about 35 to 40%. Many of the triptans, when they are suitable for the patient, patients start taking them up again and again, and then they develop a medication overuse headache. And as we discussed, there are a lot of contraindications for triptan. Also, in order to obviate this point that the quicker action triptans will have a recurrence, a long-acting NSAIDs have been added, and there have been studies that augment that effect. Like we have been using sumatriptan naproxen combination. Now there is a lighter version that is also available with naproxen 7-275. And now the buzz in the last American Academy meeting was a lot of papers on combination of rizatriptan and meloxicam 20 milligram. So this might also be helpful in situations where your triptans alone are not working that well. The second breakthrough came in the form of a titan, which is 5-HT1F receptor agonist. Now this has also been introduced in India, and you know at least part of this development. But 2 important things. When you compare the triptan effect with the diaton effect, you see 2 things. One is the vascular effect and one is the inflammatory response. Now when you see the vascular response in 5-HT1F, you see negligible. There is no effect at all with lasmiditan compared to sumatriptan. But when you see the inflammatory response, you see the similar type of compared to rizatriptan. So therefore, these are actually very, very useful in patients with those contraindications, as I said, coronary artery disease, uncontrolled hypertension, or other vascular risk associations. So these 2 trials, Samurai and Spartan, what I want you to see is the curves. The curves looks more or less similar. The lowest one is the placebo, and upper 2 are the active, or upper 3 are the active ingredients. And you see that they separate out by about 1.5 hours, and by 2 hours, actually, the difference becomes clinically significant. So all are statistically significant in compared to placebo, but the adverse effects actually are problematic. And in that, the dizziness, nausea, and somnolence, especially the somnolence, and therefore there is a black box warning that if you give this drug, the patient should not drive for 8 hours. So I reserve this drug for some of my patients who want to sleep off their migraine, 1. And secondly, the housewives who do not have to go out, and the workers, the sedentary workers, not going to industrial work or some hazardous mechanical activity. So these are the groups where, and there is a risk association where triptans might not be useful. We are using these drugs nowadays. The third breakthrough is the GPANs, right? GPANs are the small molecule CGRP receptor antagonists, and they have been all positioned for acute treatment as well as the preventive treatment. And out of the 8 GPANs, now 4 are surviving. That is rimegepant, ubrozipam, and zavizipam. Zavizipam intranasal route, and atogepant and rimegepant for the preventive treatment of episodic and now chronic migraine as well. So these are the data. Now, if you see the 3 groups, the ubrozipam, rimegepant, and zavizipam, you see more or less a similar response. Compared to placebo, there is about 10% responder rate for 2 hours pain freedom, right? Compared to placebo. Now, rubrozipam you can repeat, that was repeated after 2 hours, so you can give it another dose after 2 hours, but rimegepant and zavizipam only single, application in a day. So that is an important point to remember, right? Are these drugs better than the triptans? No, there has been meta-analysis which has shown. Now, look at this carefully. 2-hour pain-free minus placebo effect. So greatest is for sumatriptan 6 mg, 44%. Sumatriptan oral 100 mg, 20%. But for these drugs, it's coming to about 10%, right? Lasmi also about 10%. Riza is 30%, right? So these are working less in terms of the efficacy of the 2-hour pain freedom, right? Then 2-hour pain relief, again the similar features. And also you see the sustained, the last column, where you find that there the recurrence rates is varying from 20 to 25%, right? Whereas in the newer drugs is probably slightly low for some, but even comparable for others. So therefore the question comes that where do we stand? We stand here for these drugs 4 conditions. 1, triptan failure. The triptan, you have given the triptan, you have tried and changed to another triptan, you have done it 2 times, the patient is not responding to that acute medication. And it happens in quite a fairly large number of patients with a chronic migraine. You can give a GPAT, right? Triptan intolerance, patient from the beginning is not able to tolerate triptan contraindications, and the patients who are getting MOH. MOH is known with the triptan as well as the dietitian, but so far has not been reported by GPAN. So therefore, there is a case for giving GPANs in these patients. And also, it has been shown that the GPANs work regardless of treatment status. Whether in the previous time you have given a triptan or not, whether it has failed or succeeded, still the GPANs are working. So that's a great news. That is a comparison, the Rimegepant with a triptan, and always we find that these GPANs are working better. There is this recent study, the Gainer study, which is a real world study, and in which you can actually see that the rates have increased now. By 120 minutes, 2 hours, about 44.7% are becoming headache free. So therefore, what you actually see in this, pivotal trials is not reflected in the real life, because you have the additional component of placebo effect coming in and joining the actual effect of the drug. So you are getting a large majority of patients, 50% of the patients roughly, are getting a relief at 2 hours, pain freedom at 2 hours. GPANs for prevention, yes, one is atogepant. Again, we are getting a reduction of 1.7 days at a dose of 60 milligram per kg, once a day 60 milligram tablet, and this has become quite a popular drug in the West for prevention of migraine, because you just take one drug in the morning and then that's it, and you get a very gainful response. Similarly, Rimegepant, which can be given as an acute treatment and as an alternate day treatment for prevention, has also gained momentum. Although the difference here is 0.8 days in terms in the studies, but the real life figures are showing higher, and the patient is actually, you give just one drug, you say that you take alternate days, and in between, if you have breakthrough headache, you take another dose of the drug. Another thing which has happened and which is the paradigm shift is this. Now we know that there are phases of migraine, and now can we target, before this intense headache comes with all the systemic features, the prodrome phase? Answer is somewhat yes, because in a study it was found that if the patients are instructed, they are taught, they are able to identify the premonitory symptoms, 70% with electronic diary. And if they can, and if they take this Ubrogepant as an acute treatment, they've shown that the absence of moderate to severe headache within 24 to 48 hours and the most bothersome symptom within 24 to 48 hours actually is much better given compared to a placebo. So basically you are trying to kill the headache before it becomes significant enough. And if the patient is intelligent enough to know exactly, that these are the premonitory symptoms that I'm going to get it in another 24 to 48 hours, then this might be a good product. Of course, that will be cultural specific, and we need to actually define that what kind of patients that will benefit from that, and also there is a potential for misuse. The fourth breakthrough is the monoclonal antibodies. The monoclonal antibodies will target either the CGRP or the receptor. Receptor is a complex, I will not go into the details of that, but finally the action is coming through the cyclic AMP, CAMP, right, in the blood vessels, right? So therefore, you have this, antibodies which are 4 in number. The last one to come was the Erenumab, VAPT, and that is given intravenously every 3 months. And then we have got 3 subcutaneous forms like Fremanezumab, the Galcanezumab, and Erenumab, which can be given monthly injections, and Fremanezumab can also be given quarterly injections, right? So therefore, these have changed the entire paradigm of treatment in migraine, because you would like, just like a subcutaneous injection for 1 month, long T half, and you patient is getting a significant relief from migraine, so you don't have to take medicines again and again every day, forgetting it, and you are getting a benefit which was not seen by the conventional medicines. You are getting a MMD, that is a monthly migraine days reduction of about 2 to 2.5 days, which has never happened with the oral medicines. That was around 1.5 to 2 days, right? So that is a great thing. And 50% responder rate, which was about 50% for the conventional drugs, has also improved. For the test drug, now it's about the range of 43 to 62%, depending on various maps, and the placebo effect is about 30%, right? So therefore, they are slightly more, slightly better in efficacy than the conventional drugs, with the added advantages. And if you see, in compared to the placebo, the odds of getting a good response is in the range of 2 to 3. So 2 to 3 times the patient is likely to benefit, even if given a placebo versus a monoclonal antibody. So therefore, there are pluses and minuses for these drugs. The first is, of course, the convenience, as I said, slightly better efficacy, acceptability and adherence. People accept it and adhere because there is not much side effect and very easy to use. And some of these are having very quick effect. In conventional drugs, we need to wait for weeks, but now we don't have to wait that much. Within 4 weeks, within 2 weeks, the effects are coming. And in a small proportion case, I have got about 4 or 5 patients who had years of migraines, and after starting Erenumab, their headaches have just gone. This is unprecedented. And when I'm saying it, to believe me, this might look like there are patients who have not responded. There are quite a few of the patients who are not responded. But people who have responded, some of them have responded remarkably well. And that is a thing which I find is really, really surprising. And the cost and adverse effects are minimal. Constipation is an important problem with Erenumab. There might be slight rise in BP with Erenumab, local rash, pruritus, and of course the non-availability. Are MAPs good for India? Yes, we did the Empower study and we found that it's actually similar, 1.7 days compared to the Western data, right? So we are actually faring similarly with the MAPs, and efficacy persistence. If you see that both the groups, those who received the placebo, the black line, that when they started receiving the Galca, and the people who were receiving the Galca throughout were actually having the persistence of effect till 6 months, right? So we can give it for a long time, and there are people who are giving it for years together in the West, and they are actually reluctant. Patients are reluctant to leave this medication. So how do MAPs fare compared to the established oral drugs? So this is a complex network meta-analysis. There's no direct head-to-head comparison except for one I should show. But if you see that this one line, the vertical line is showing the number of days, and the horizontal line is showing the dropouts. And you see that CGRP is both better in number of days. It's 2 to -2 plus MMDs, and also it is the least dropout rate compared to the conventional drugs. And there is this Hermes study from Germany which has shown that if you give topiramate and compare topiramate and Erenumab, topiramate about 40%, 38.9% people are going to leave it by 24 weeks, but Erenumab it's about 10%. There is a real world data of a large number of studies which has now been meta-analyzed and systematic review have been done, which has shown that if you give these drugs over a period of time, actually there is an accumulation of effect and people start getting more and more. That is one part. And the dropout rates actually drops down to about 6%, which is very less, So most of the people are continuing with these medications. And of course, the adverse effects that were even at the real world, that were found: constipation, reaction, dizziness, muscle cramps, pruritus. Raynaud's is an important thing that many people with the Raynaud's may develop, because that is a skin CGRP might be affected. So that you need to be considering, and rash and urticaria, and small blood pressure increase with initiation of Erenumab. Now, what has happened after the introduction? So now it's about 3 or 4 years of regular use, or 5 years of the initiation. So what has happened? The landscape has opened up. Now we have got a lot of questions. How long would you like to give? 3 months, 6 months, 1 year? Would you like to give a gap? There are divided opinions about that. What is the long-term adherence and dropout rates? That we need to know. We have shown that it's about 6% mostly, but we have to see a longer. There are a lot of people who receive this by the end of this month, the 4th week, they again start having the headaches. So is there any wearing off effect? That we need to look at. headache recurrence after stopping. It has been shown that if you stop the drugs after giving for 6 months, within 3 months again they go back to the pre-morbid level. The switching treatments, that whether you give one map, it doesn't act that well, then would you like to give some other map with a different site? One is a receptor blocker, one is a CGRP blocker. Similarly, with the medication overuse, patient with aura, children, adolescents, can you combine with the GPANs? That is an important question. Can you combine with Botox? So all these landscapes are evolving and new studies are being envisaged and devised and being undertaken to answer this question. And some of these aspects are actually dealt with in my chapter on this book on advances in headache medicine. You can go through it and you can get a fair idea of what is happening. And of course, there's an update that is coming on a new book that I'll share when it is released. And finally, the success of a drug is, I know how much dislike we have for this, so-called doctor pharma networks or, nexus and whatever you may call, right? But, you have to accept that whatever the new drugs are coming, they are coming because of this pharmaceutical giants, their research, their investments, and they obviously would like to take back their portion of investments, right? So your prescription patterns will reflect that by the markets that are shared. Now, what do these markets say? Total estimated migraine treatment is about 2,812 million USD. And you see that North America is 40%, but Asia Pacific is 23%. That's why many of these drugs are coming to India and China, right? We are having a huge market, right? And if you see the class, the triptans in acute treatment still hold about 60%, but the CGRPs are coming up 15 to 20%, and preventive atogepant 11%, and anti-CGRP about 30%. So that reflects the way the physicians are seeing these molecules and prescribing them across the world. So there is a great change in our understanding, in our application, and in our recommendation of a particular treatment, and we have become much more, we have much more wider choices now to treat the migraine patients individually. So as I conclude, I will say that we have choices now. Now we can do the best that is possible for that particular patient. Earlier, 10 years or 15 years down the line, we didn't have those choices. Migraine-specific drugs are available and they should be used, and they are making a great change in the lives of these patients. That is very, very important. There are more in pipeline, like for example, PACAP is coming, like pituitary adenine cyclase polypeptide, right? So PACAP, either inhibitors or the receptor inhibitors or the inhibitors of the molecule, one study has become negative, one study has become positive, right? So they are coming. So can we add that with the MAPs or the GPANs? Whether the patient will become much less frequent headaches with that. There are lots of other targets that I'll not go into the detail that are coming, and we will be flooded with this kind of drugs. Next 2 decades will be used to refine our practice. We will become more patient specific. We'll have the data of predictive AI algorithms that this patient will probably respond well to this particular drug. This will happen. This is coming. And this will happen in your mobile. You will have this simple touch, and you will know that, okay, this is the patient profile. This person is very likely, and you insert those parameters, and this patient is likely to benefit from this drugs. So this is coming. So freedom from headache, we say that it's genetically driven. It's not, cure is not possible, but freedom from headache, making it very less, very occasional, and living a normal life, it's no longer an utopian idea. So I encourage all the youngsters to join this bandwagon, join this field. You have so much to do in this, and so much research is possible, and we have a large country, and now at least I am in a position to facilitate, if you want to collaborate with somebody, some institution, some person, in terms of research, in terms of collaboration, please contact me. But do join it, and don't take it that this is a, kind of a lusterless, a lack of, that aura and those kind of things. Headache medicine has a lot to offer to you as a for professional growth and to the patients for better treatment. Thank you very much.
Beautiful, encouraging lecture. We would request the panelists to answer them to kindly share a few words. Sir?
Thank you, Professor Chowdhury, for your excellent lucid lecture. You are a great orator, there is no doubt, and everybody knows this thing. And you were so simply you express this treatment policy from Ergot to recent one. That will be very classical one. Thank you, and you come forward for these researches and help in this headache researches or even the clinical trials. And I request everyone, if those who are interested, to contact with Professor Chowdhury, and that will be helpful for all of us. And it will be the public will be benefited, people will be benefited from this precious. Because most of the probably 90% people are having some sorts of headache in their lifetime. Thank you.
I'm free today. You can ask me a couple of questions if you want.
Sir, I'm asking about your personal practice. Do you stop Erenumab after giving for 1 year?
Yes, I do.
For 3 months?
Yeah.
Okay. But not after 6 months?
No, I mean, I continue. 1 year data
1 year
is
data is
almost
available.
enough that
Yes.
it doesn't produce any. See, the problem, another thing is that I'll tell you at this point, I didn't touch this, that this modification of the, maps is not on the immunological side. This is a specific modification based on that particular receptor. So, immunologically, the patients are not going to be harmed. Only problem is that we don't know yet the long-term inhibition of the CGRP or CGRP receptor, because they do a lot of positive things for the body also, like bone metabolism, like gastrointestinal metabolism, gastrointestinal tract. So we don't know the long term, but so far so good, right?
And the second question, we see few patients who have an excellent response in initially giving Erenumab. After giving 6 months, 7 months, or maybe more than 1 year, the effect is not that well seen. How do you manage these patients, sir?
So I have got a few patients like that. So in that you have to either switch to the Erenumab is not available. But otherwise I would have gone to for Erenumab. But in that case now I'm hopeful that Rimegepant is coming to India. At least we will try Rimegepant, and then of course we will try botulinum toxin. Or we are now doing basically for most of the refractory patients who are not able to pay that much. So we are using a combination of. There's already a international. My trial is going on combining botulinum toxin and gadoxapatina blocks and how for the refractory migraines. So we are trying that, and of course neuromodulation along with that, because now there is some neuromodulation devices available.
One question I would just like to ask you, but there is some article which I've seen showing the efficacy of galcanezumab in cluster headache. So that's not available here. So what do you think about that?
Yeah.
Does
So
it work?
Yeah, so Galca, what Peter study was showing that this about 300 milligram of Galca every month is going good for episodic cluster headache, but not for chronic cluster headache. Now 300 milligram is not available. Mostly it's only available in the US. So we have got 120 and 240, right? So now I've been giving about this 240 milligram Galca and episodic migraine, that is helping. And some of the patients of chronic migraine also have given, chronic cluster also have given, because there was no other option available at that time, right? I remember one patient who is a PhD scholar who is working in Zurich. So he comes and he gets this thing, and I inject here. The point is this, that the other maps, they have failed. Erenumab has failed. Recent study of Erenumab has failed, and there is now a publication which is due, which is coming in next month in a Journal of Headache and Pain. So this is called the Hallmark series, right? So they have published a Hallmark series on migraine, Hallmark series on TTH, and this is time they are publishing Hallmark series on cluster headache. I am also an author in that entire group. There are 40-50 international people. So in that we have actually discussed this possibilities that how will that be, but it does help. Now in US and Canada, that has become the norm, that they are not giving verapamil as a first line, they are giving Galca as a first line for episodic cluster headache.
Thank you, sir. Thank you for your enlightening lecture. So I would request Professor Debashish sir to felicitate Debashish sir. also our respected panelists.
Thank you so much.